Okay, let's start with Surah Al-Fatiha. Okay, can start.
Okay, Bismillahirrahmanirrahim. My name is Faiz bin Rahman. So I will start presenting my case. For today's case, right, an 8-month-old male infant presented to emergency department of HTAA with fever and cough for 4 days duration. The history was taken from the patient's mother. The patient was relatively well until 4 days prior to admission as he developed fever, which was sudden in onset and was not associated with chills and rigor. The documented temperature at home was 37.5 degrees Celsius. The fever subsided with paracetamol but only temporarily and then persisted for 4 days until the day of admission. The onset of fever was also associated with runny nose, which also lasted for 4 days. The nasal discharge was clear in appearance. 2 days prior to admission, the patient started to cough. The cough was non-productive and was described as barking cough. There was no history of sick contact, recent travelling, or going to crowded places. His mother noticed that he babbled less since then, but she was not sure about any hoarseness of voice. The cough became persistent and caused him to experience 3 episodes of post-tussive vomiting 1 day prior to admission. It happened post-feeding and the vomitus was minimal in amount and contained milk only. Since then, his oral intake became poor. There were also 3 episodes of loose stools 1 day prior to admission. The stools were poorly formed but not entirely watery. Otherwise, there was no overflowing diapers. The stools were yellowish in color but no mucus or blood present. There was no history of eating outside food and no one in the same household had the same symptoms. There was also no recent change in his diet, plus the patient did not come from a dengue-prone area. There was also no recent water activity. 6 hours prior to admission, the patient started to breathe rapidly as he was playing with his toys by himself while being observed by his mother. Otherwise, his mother denied any noisy breathing. His mother did not notice if the patient put anything inside his mouth. There was also no choking episode. There was no excessive drooling, chest indrawing at the supraclavicular or subcostal area during the rapid breathing. There was also no bluish discoloration of the lips or presence of cold extremities. The patient had history of hospital admission once with the same presentation and was hospitalized for 4 days. According to his mother, the patient received nebulized drug in which the mother was not sure about the drug, syrup paracetamol and antibiotics during the admission. Upon further questioning, the patient was brought to the GP on day 1 of fever. He was prescribed with syrup paracetamol. No antibiotic was given. On the day of admission, he was brought to the GP first and received nebulized drug once there, and then he was referred to HTAA as the GP told the mother that his respiratory rate was fast and he also had chest recession. At the emergency department of HTAA, he received nebulized drug twice before being admitted to the pediatric ward.
Okay,
Um,
stop now. Stop. So the patient received nebulizer twice.
mm, Twice.
Twice. Okay. This is the second time. Yeah.
Second time.
And both times he required admission.
Mm, Both time required
Okay.
admission.
Did he require nebulizer at any time without admission?
Mm, no.
No. This case is from the previous groups, is it? We have
Yes.
taken from the previous groups.
Yes.
Yeah. Okay. So if you are the one clerking, need to ask specifically whether he required nebulizer in between or not, because requirement of nebulizer is not always admission. Many children receive one dose nebulizer, then they improve and go back home. How old again is the child?
8 month old.
8 months old.
Mm,
Okay. And the previous one at what age? The previous dose of nebulizer?
the previous one. During 8 month old also.
During 8 months old.
Mm,
The interval between them?
Not stated.
Not stated. But must be short interval, for the
Mm.
same age. Mm. Okay. So the child requires nebulizer. What type of nebulizer do you think?
I think of based from the case.
Mm-hmm.
Based from the case, and it was not stated because his mother did not remember, did not sure about the drug.
Not sure. Okay, not
No.
stated. Okay, fine. From your basic knowledge, what medications are given by nebulizer? Can you tell me? Okay, open a question. Anyone can tell me example one medication given by nebulizer?
Adrenaline,
Adrenaline. Yes. More common.
budesonide,
Okay,
Salbutamol.
budesonide. Yes. More common.
Albuterol in
Salbutamol.
Sorry.
albuterol in asthma.
Salbutamol. So the most common is salbutamol. Salbutamol is the most common. Okay. So salbutamol. This is the most common. What is salbutamol?
Beta 2
Okay, open a
agonist.
question. What is salbutamol?
Beta 2 agonist.
Beta 2 agonist. So what does very good. What does it do? What is the function of beta 2 agonist?
Bronchodilator.
Bronchodilator. Why bronchodilator? How it causes bronchodilation?
Inhibit beta 2 receptor in which beta 2 receptor usually cause bronchoconstriction.
It binds to beta 2 receptor. Beta 2 receptor. This beta 2 receptor is G protein. G protein coupled receptor. G protein coupled receptor. So when salbutamol bind, there will be change of adenylate cyclase, activation of adenylate cyclase enzyme, which convert ATP to cyclic AMP. ATP to cyclic AMP. What cyclic AMP do? Cyclic AMP will inhibit myosin light chain kinase. Cyclic AMP inhibit myosin light chain kinase. This myosin light chain kinase is needed for phosphorylation of myosin for myosin to bind with actin and causes contraction. So when you inhibit myosin light chain kinase, there is no phosphorylation. So you are causing muscle relaxation. This muscle relaxation leads to bronchodilation. So which clinical condition required salbutamol?
asthma,
Why asthma requires salbutamol?
Asthma is
Mhm.
a form of obstructive. Asthma is a form of
Obstructive. What does that mean?
uh,
What is
tr-
the meaning of obstructive?
it causes bronchoconstriction in which
Yes, very good. Very good, Ada. Yes, yes, it is like this. So in asthma, we have bronchoconstriction. We use beta 2 agonists to cause broncho relaxation. Yeah, that's asthma. So, do you think this baby has asthma? 8 months old. Can he has asthma?
I'm not sure.
Yes.
Yes.
Not sure. Very good
Yes,
answer.
asthma
Mhm.
diagnosis 3 years
Yes,
and above.
asthma
Diagnosis 3 years and above usually.
usually. See, it is difficult to diagnose and label child with asthma, but still it is possible. It is not easy, yes, it is not easy to say that it is asthma, but it happen. Yeah. So don't say it is impossible because some students say It is impossible for asthma before 3 years. There is no asthma before 3 years. No, this is wrong. It happens, but it is not easy to diagnose because there are many conditions mimicking asthma, present like asthma. Many respiratory conditions in young infants present like asthma, and they cause wheeze of the child, make the child wheeze, but then children grow and no more wheeze episodes. So that one, it is not asthma, it is other condition. So that's why this is the thing which we need to know whether this child has asthma or he has other condition. It is clear that he has wheeze. He has wheeze because he required nebulizer twice, salbutamol nebulizer twice. Whether this wheeze is asthma or not, the history and physical examination will tell. So very important point supportive for asthma is interval symptoms. Interval symptoms. What is the meaning of interval symptoms? Means the symptoms in between. You see now, this child has required nebulizer one time, require admission. Now again, require nebulizer and require admission. So we need to ask how is he in between. In between, we need to ask specifically about nocturnal cough. Don't just ask how is the child in between. If you ask how is the child in between, mother may say, child is okay. No, this is not correct. You have to ask, does the child cough at night? Because many mothers, they think that the child cough normal cough. It is not normal. We shouldn't cough at night. If we cough at night, this is abnormal. So very important in these cases to ask about interval symptoms in the form of nocturnal cough. Is there any question about interval symptoms, guys?
No.
No. So if you clerk by yourself next time, if you see a case like this, you need to ask about interval symptoms. Yeah. Anyone can give me example for any respiratory condition which cause wheeze? Mhm. Example for any respiratory condition cause wheeze. What is definition of wheeze? Can someone tell me what is definition of wheeze?
High pitch whistling sound.
Wheezing sounds caused by
Upper respiratory tract. Apa kalau
lower. Wheeze
lower
is caused by lower. Lower respiratory tract. What problem in lower respiratory tract? What problem?
airway obstruction.
Incomplete obstruction or partial obstruction. Partial obstruction caused by partial obstruction of lower respiratory tract. Not complete. Why not complete? What happens if we have complete obstruction? Silent chest. You will not hear anything. If you have obstruction, this is airway. This is airway. If it is blocked completely, so cannot. Silent chest. Silent chest. But in asthma, this wheeze is caused by partial obstruction, narrowing. So there will be turbulent flow. This turbulent flow is the one which causes the wheeze. The one which causes the wheeze. So asthma is one example. Another example, asthma is caused by bronchospasm, spasm or contraction of the muscles. If we have airway edema, if we have edema in the airway,
Angioedema.
angioedema, okay? Can. What else? What is the common respiratory infection in first year of
Pneumonia.
life?
Bronchiolitis.
Bronchiolitis, very good. Bronchiolitis. Bronchiolitis, yes, bronchiolitis can cause airway edema and narrowing of the airways, and then it can cause wheeze. One of you said the pneumonia. Who said the pneumonia?
Me, doctor.
Okay. Can you tell me which type of pneumonia which can cause wheeze? Bronchopneumonia or lobar pneumonia?
Bronchopneumonia.
Bronchopneumonia, very good. Your answer is correct. Why bronchopneumonia, not lobar?
Lobar, it involves the loop.
Lobar pneumonia, yes, certain lobe, and involves the alveoli only. Alveoli does not go to the bronchioles. So that's why there are crepitations, but no wheeze. In a bronchopneumonia, the name, they say broncho. Broncho means bronchioles are involved by inflammation. So there will be narrowing, and then we will hear bronchi. So this one will tell us, unfortunately, from the history, the original history, it was not taken. If the child has positive interval symptoms, we will think in asthma because asthma is a chronic condition. And the most important interval symptom is nocturnal cough. If it is pneumonia happening twice or bronchiolitis, usually in between the child will be fine. The child will not have nocturnal cough. The child will not have nocturnal cough. Okay, other differential diagnosis. So now your differential diagnosis is bronchiolitis, asthma, bronchopneumonia. Did you hear about condition called viral induced wheeze? Viral induced wheeze. Anyone heard about it?
Groups?
It is different from croup. Viral induced wheeze. Croup is not is different. Croup is another condition. Viral induced wheeze means the child gets respiratory tract infection, upper respiratory tract infection. Then after that, he developed wheeze. He developed wheeze, like sensitivity of the airways. Yeah, sensitivity of the airways because of viral infection. So it is not a pneumonia, but the patient gets the inflammation in the upper airways. After that, he developed reaction and bronchospasm and developed wheeze. That is viral induced wheeze. That is viral induced wheeze. Okay, carry on.
Okay. Next for systemic review. General, there was very mild resolving eczema on his cheeks. Otherwise, there was no other skin
Okay.
changes.
Muhammad Afiq, you heard what he said.
Yes.
Yes. What's your comment?
Yes, doctor.
Did you hear what Faiz said now?
Yep. Sorry?
Did you hear what Faiz said just now?
Yes. He talked
So,
about systemic review.
Systemic review, okay?
About systemic review.
Systemic review. So what I said first point in systemic review? You repeat, Faiz. Repeat again.
There is eczema on
Eczema. Okay. So what's your comment when there is eczema? What's your comment about possibility of asthma? Higher or less? When you have eczema, your chance to have asthma more or less? Okay, open question. Is it more chance to have asthma when you have eczema?
More. Yes.
Yes.
Yeah, yes. When you have eczema, it's more chance to have asthma because atopy, they are associated. Yes. Asthma, allergic rhinitis, and eczema, they are associated. We call them atopy. Many people, they have eczema and they have asthma. So this one is supporting point for asthma. You see, like we said, it is not easy to diagnose young infant with asthma, but it happened. So now we have one supporting point is eczema. Another supporting point we will see later is the family history. Family history. So 3 supporting points. The interval symptoms, unfortunately, we don't have from the history. We are not sure whether the patient has interval symptoms or not. We have 1 supporting point now, eczema, and later on, when we come to the family history, we see if there is family history of asthma, it will be supporting point. Okay? Yes, carry on. Right.
Okay, for cardiovascular system, there was no issue with feeding, such as interrupted or prolonged feeding, or even breathlessness during feeding, no cyanosis or pedal edema. For
Very
respiratory,
good. Nur Aizatul. Nur Aizatul Akmal. Yes, so now he reviewed the cardiovascular system. What's your comment about cardiovascular system review?
Sorry. Can you repeat about the cardiovascular system?
okay,
Yeah.
there was no issue with feeding, such as interrupted or prolonged feeding, or even breathlessness during feeding, no cyanosis or pedal edema.
So if the feeding is interrupted and if there is prolonged feeding and scalp sweating, what will you think in? What condition?
It is an effect of beta 2 agonist.
No, the
Is it a
now
side effect of beta 2 agonist?
no, the child did not start treatment yet. Now this is from the history. He is telling if the child didn't start treatment and the mother tell you when he takes feeding, he needs to take longer time than before. And he becomes tachypnic after feeding and he develops scalp sweating. So do you want to think in another system pathology other than respiratory system? Do you want to think in heart failure?
Not so. Not so.
Yeah,
I
heart
think
failure. Yes,
it's
we
more
think in heart failure.
other system like GIT instead of CVS.
We we need to think in heart failure. If the feeding is interrupted or prolonged or develops scalp sweating or breathlessness during feeding, this is related to heart failure. You see heart failure symptoms if you go to internal medicine, patients become dyspneic when they make effort. When they make effort, like when they walk or when they run, when they climb stairs. For infants, they make effort in the feeding. Otherwise, they are quiet in their place. So when they start feeding, if they have heart failure, they will become tachypnic, dyspneic. They need longer time to finish their feeding, so their feeding will be interrupted, and then they will have scalp sweating. Yeah. So this is the review of cardiovascular system. Because you see, when we see that child with respiratory distress, it is not always respiratory system. It may be cardiovascular system. Commonly, yes, commonly respiratory system, but it may be cardiovascular system. And from my experience, more than 16 years, I saw many babies admitted to the ward as diagnosis of pneumonia or respiratory disorder. After that, would review again, we found them to have cardiovascular disease rather than respiratory disease. Okay? Yes, carry on, Faiz.
Okay, for respiratory system, there were no noisy breathing, cyanosis or hemoptysis. For gastrointestinal system, there was no constipation, hematemesis, hematochezia or melena. For genital urinary system, there was no hematuria, frequency of fruity urine. For neurological system, there was no
What
abnormal
are the
movement,
symptoms in urinary system in babies? You said hematuria and
hematuria, proteiurine,
what else? Any other symptom? The patient is
frequency.
boy, is it? Is the patient boy?
Yeah, yes, boy.
Boy. So what system during micturition, which may indicate congenital anomaly in the boys? Interrupted stream. Very good. Yes, interrupted stream. What is the name of the congenital anomaly which causes interrupted stream?
Posterior valve.
Posterior urethral valve. Very good. Posterior urethral valve. Yes. Which happens in males only. Okay. Carry on.
Okay, for hematological system, there was no bleeding tendency such as easy bruising, epistaxis or gum bleeding. Head and neck, there was no area discharge or lymphadenopathy.
Mm-hmm.
Okay. Next, for past medical history, during antenatal, the mother suffered from hyperthyroidism and anemia during pregnancy. She required 1 pint of blood transfusion during her second trimester and was treated with Venofer. Otherwise, the mother denied any other medical problem during pregnancy, including GDM and pregnancy-induced hypertension. Um, Intranatally, the patient was born preterm at 36 weeks of gestation via spontaneous vaginal delivery due to early contraction. His birth weight was 2.4 kg with length of 48 cm. There was no complication during the delivery. During postnatal period, the patient was admitted to NICU for 21 days and was required continuous positive airway pressure during the first week there. He also had jaundice, which was
Okay. Why the baby required continuous positive airway pressure?
I think maybe the patient was born preterm.
Preterm. Very good. So you think it may be something related to prematurity. So what is the common condition which happen in premature babies and cause them to have respiratory distress and require CPAP?
Decreased lung surfactant.
Decreased lung surfactant. Very good. What is the name of the condition?
Um,
Anyone knows? Open question. What we call that condition? Decreased surfactant. عواطف.
I'm not sure, doctor.
Not sure. Okay. Anyone?
Maybe
It is
respiratory
called
distress.
respiratory distress syndrome. Respiratory distress syndrome. RDS. Be careful. Don't say ARDS. It is RDS. It is different. ARDS is different from RDS. ARDS is acute respiratory distress syndrome, which happen in older children and adults, like COVID-19. COVID-19 can cause ARDS. ARDS. What happened in premature baby is RDS, not A. كلو شك بإيه صلاة. So RDS, respiratory distress syndrome, or another name, hyaline membrane disease. Hyaline membrane disease. So respiratory distress syndrome or hyaline membrane disease. It is because deficiency of surfactant. What is surfactant? Open question. What is surfactant?
It helps to reduce the surface tension of the alveoli. So when the baby inhale, there is more gaseous exchange.
Very good. Very good. Very good. Yes. There is more gas exchange, prevent surface tension. Surface tension is collapsing force. Collapsing force. So this is the alveolus. When there is surface tension, the alveoli collapse. Collapse. Stick in each other. No air. Air تبولي مسو. udara تبولي مسو. سبب collapsing force. So when you have surfactant, it reduces surface tension, so the alveoli are kept open and you have better gas exchange. Okay? Fine, carry on.
He also had jaundice, which was confined to the head and neck. He received prototherapy for 3 days. The patient also had underlying G6PD deficiency, which was diagnosed right after he was born. He had a strong family history of G6PD deficiency from his father's side. He had never been
Why he has
admitted.
jaundice? What was the cause of his jaundice?
Not sure. Tak
Not
ada nama.
sure. Okay, jaundice, neonatal jaundice must have a cause. So now you said the baby has jaundice and has G6PD deficiency. Can a G6PD deficiency cause jaundice?
Yes.
Mm. Yes.
Yeah, so that is the cause. Yes,
Oh.
so that's the cause. So it is better when you pick up the information from the mother, baby has neonatal jaundice secondary to G6PD deficiency. You see, because always you must, if possible, to tell the diagnosis till it. Neonatal jaundice is not a diagnosis. Jaundice is not a diagnosis. Jaundice must have problem. In this case, it is a G6PD deficiency. So tell your jaundice, is it ABO incompatibility? Is it RH incompatibility? Is it sepsis? Is it physiological jaundice? Yeah, you must tell. So in this case, it is a neonatal jaundice secondary to G6PD deficiency. Okay,
Okay.
carry on.
Okay. He also had underlying hypothyroidism, which was also diagnosed soon after being born. His mother had
Okay. Anyone? Anyone wants us to tell something related to the event is happening? Can congenital hypothyroidism cause jaundice?
cannot.
Can. Boleh lah. So congenital hypothyroidism can cause neonatal jaundice. Congenital hypothyroidism can cause neonatal jaundice. G6PD deficiency can cause neonatal jaundice. So your patient has two causes of neonatal jaundice. Two causes of neonatal jaundice. And your patient is lucky he was born in a country which makes a screening program for hypothyroidism. This child is lucky because he was born in a country where there is national screening program. Why he is lucky? Why he is lucky?
We can treat him earlier.
Yes.
Because
We
thyroid
can treat
is
earlier.
Treat early before appearance of symptoms, and the prognosis is good. They will live normal like us. So if you detect congenital hypothyroidism, that's why it is cost effective. Screening program for congenital hypothyroidism is cost effective. So this boy, imagine now if he was not diagnosed, what will happen to him? He will have developmental delay and he will be mentally retarded. And the problem, when he is mentally retarded, if you diagnose him late, treatment is not helpful. Treatment is not helpful if you diagnose him late. You need to diagnose early. And imagine now you paid for the screening test, small amount of money. Imagine if he is not screened and then he becomes mentally retarded and with developmental delay. So you need to pay money to him all his life, and he will not serve the society because he will be mentally retarded. But now this boy will grow up, so he may become a doctor, he may become engineer, he will be useful for the society, and he will bring the money to the society. So that's the thing. That's why screening program for hypothyroidism is very good. It is cost effective. Okay, carry on.
Okay, on. His mother had hyperthyroidism and was on treatment during the pregnancy. Currently, the patient was on thyroxine. He used to receive a higher dose of thyroxine but was tapered down to the current dosage on recent follow-up. His regular follow-up was at Klinik Kesihatan Kuantan. Also, the patient also suffered from eczema since he was 6 months old. At the
Again,
moment,
his mother has hyperthyroidism or hypothyroidism.
hyper.
Hyperthyroidism. Okay, okay. Mm-hmm.
The patient also suffered from eczema since he was 6 months old. At the moment, he was not using any topical cream for the eczema.
Mm-hmm.
For drug history, as stated before, he was on thyroxine for his hypothyroidism. Other than established triggers of hemolysis in GXPD deficiency, he had no non-drugs or food allergy. His mother denied giving him any other supplemental medication. For past surgical, there was no non-past surgical history. Next, for nutritional history, the patient was fed via nasogastric tube soon after he was born. He started to be breastfed on day 16 of life. He was breastfed around every 2 hours and on demand. At 4 months old, he was introduced to Enfamil formula milk, around 4 feedings per day and 5 fluid ounce per feeding. He still consumed breast milk at the same time. After that, at 6 months old, he stopped consuming formula milk and returned to full-time breastfeeding. Soon after that, he started weaning with purees and eventually with other food. Now, currently at 8 months old, he had already been eating porridge, blended chicken and fish. He was usually fed 3 times daily and still being breastfed. Next, for growth and developmental history. For gross motor, the patient could sit without support, put himself to stand, and stand with support. He could also roll over from supine to prone position. For
So like
5
here, well, good development.
Mm.
Yeah, if he was not diagnosed with hypothyroidism and was not treated, he will have
development.
developmental delay. Okay,
For fine motor, the patient showed palmar grabs of cube and could transfer the cube from one hand to another. He also looked in the correct direction for fallen toys. For speech or language, the patient responded to his name and turned his head toward sounds.
very
He,
good.
he also babbled in single syllable. For social behavior, the patient stretched his arm out when when wanted to be carried. He understood when someone said no. He did not seem to be anxious around strangers. He could also wave bye-bye.
Very good. Very good. So very good development. All milestones of development are very good. Okay.
Carry on for immunization history. His immunization was up to schedule according to his age. The last vaccine he received was hepatitis B. So far, he had never experienced fever or allergic reaction following vaccination. Other than that, he did not take any other additional vaccines. Proceed to family history. His father was 30 years old with underlying dyslexia deficiency and allergic rhinitis. His mother was also 30 years old with underlying hyperthyroidism since 2016. She also had allergic rhinitis. The marriage between the parents was not consanguineous. The
So
patient,
what's the comment now? Now tell me as related to the child. Yeah, what is related to the child?
both his parents has allergic rhinitis.
Okay.
My
So is
high
this supporting for asthma?
high risk of getting asthma.
Yes. High risk means there is his family history of atopy, so higher risk of getting asthma. So now, and his father, you said, has G6PD deficiency.
Hmm. Yes,
So do you think the child got the condition from his father?
I think yes.
You think yes. Anyone think no? Anyone brave and say, I think no? I would say no.
Okay.
He didn't get from his father. Why?
because it is X-linked recessive.
Yes, it is X-linked recessive. And he is a boy, XY. So he will take the Y from his father. He will not touch, he will not touch the X of his father. So he got it from his mom. He got it from his mom. His mom is a carrier because she has 2X. His mom is a carrier because she has 2X. That's why the disease was not manifested in his mother. Can girls get the G6PD deficiency? Can they manifest the G6PD deficiency? Do you think it is possible in girls to manifest the G6PD deficiency? They have 2X. Anyone wants to try? It's still possible. In this family, particularly in this family. Why? Because now the father is affected. The father is affected. Father has G6PD deficiency. So his X is affected. The mother is a carrier. So she has one normal X and one affected X. So her daughters, it is possible that they get one affected X from her and affected X from father. Then they will have the disease. So unusual for X-linked recessive disorders, commonly seen in the boys, but rarely may happen in the girls. Any other condition? Do you know one syndrome called Turner syndrome? Anyone heard about Turner syndrome?
Yes.
Yes. Who said yes? Awatif. What is
Yes.
Turner syndrome?
Um, the female. Wait.
Mhm. Yes, the female would.
The female has miss one of the X chromosome.
Yes, very good. So in Turner syndrome, the female has single X. So if Turner syndrome with single X, she may get X-linked recessive disease because only one X, no protective X, like Turner syndrome. Okay, is there any other phenomena, Awatif, other than Turner syndrome?
I'm not sure, doctor.
Not sure. Very good. Okay. Radha, Radia.
Yes, doctor.
Is there any other phenomena can bring
Regarding
X-linked recessive in girls? Did you read something can bring the X-linked recessive disorder in the girls?
mm, I'm not sure, clinical
Not,
filter.
not sure. Okay. There is one
It's a
phenomena called
boy. No,
lyonization.
sure.
Yeah, lyonization. Lyoni. Lyonization. Lyonization. So lyonization can bring X-linked recessive disorder in the females. Lyonization. Lyonization. Lyonization means inactivation of the normal X. Inactivation of the normal X. That is lyonization. So when the normal X is inactivated, so the defective X becomes predominant and manifest clinically. Okay, carry on. Faiz.
Okay, the patient had a healthy 6 years old sister. His mother had a miscarriage before conceiving him. It happened because the mother received a higher dose of carbimazole for her hyperthyroidism. That's what the mother said.
Mm-hmm.
And then the patient's paternal grandfather and paternal uncle also had G6PD. Otherwise, there was no family history of asthma or eczema in the family. There was no malignancy or autoimmune disease in the family. Okay, next for social history. The patient, along with his parents and sister, lived in Sungai Isap, Kuantan. The house was equipped with good water supply and electricity. His father worked as a banker, and he was an active smoker since the age of 12 years old. He smoked 10 cigarettes per day, but never inside the house or in the presence of the family members. His mother was a full-time housewife. That's all for the history.
Okay.
And then for physical examination, the
Do you want to
patient,
tell us summary of the history?
summary of the history.
Yes.
Okay. For the summary, Right, 8 months old male infant being referred to emergency department, presented with low-grade fever, non-productive barking cough, post-tussive vomiting, rapid breathing, coryza, and chest recession. He also had loose stool. And the patient had underlying GCSPD deficiency and hypothyroidism, and was on thyroxine for his hypothyroidism. That's all for the summary.
So see, summary, you need to arrange it. Need to arrange summary in a nice way. You have 5 components to make summary. You have 5 components. Number one, the background. I think we mentioned it in the previous class, history taking with the whole
Mhm.
group. Yeah, when you make summary is very important. So number one is the background, which include the name, age, gender, nationality or race, and any underlying problem since when. So see your notice. What is number two?
Number 2 is
Control status.
Yes, control status or baseline of the clinical condition. Number three,
Long-term medication.
long-term medication, and since when, and we need to tell the dose per kilogram. Okay. Number four,
Number of admissions.
very good. Number of admission. Number five,
Indication of admission with main complaint.
indication of admission with the main complaint. Okay. So let's go, Faiz. Take these 5 parts together. So let's go to part one. The background. Tell us the background. Faiz, we can't hear you.
right. Can you hear me?
Yeah, can hear. Ryan. Okay. Ryan.
Right. Right. 8-month-old male infant
Mm-hmm.
with underlying hypothyroidism and GCSPD deficiency,
Mm-hmm.
and was on thyroxine
You
25
see,
mg.
well, it is not enough to say underlying hypothyroidism. You have to say underlying congenital hypothyroidism, diagnosed at birth by neonatal screening program. Because different, we see hypothyroidism, it may present with symptoms, it may be acquired. So this one, Ryan, 8 months old with underlying congenital hypothyroidism, diagnosed at birth by national screening program and on thyroxine since birth.
Since birth.
On thyroxine since birth. Okay, if you don't tell the dose, it's okay because it will make prolongation. So congenital hypothyroidism diagnosed since birth by national screening program and on thyroxine since birth. What else he has? Underlying also G6PD deficiency, also diagnosed by national
National
screening
screening.
program. National screening program. What else in his background? Otherwise, he was doing very well apart from one admission 1 month ago due to respiratory disease and required nebulizer. So that is the background in Ryan. Okay, can you repeat the background?
Doctor, that was only the background or for the medication also, including based from what you have
Mm-hmm.
if that's just the background only or it's also
Medication is included here.
uh,
Medication is included here. Yes.
okay, I repeat, Ryan, 8 months old male infant
Mm-hmm.
with
Yes.
underlying congenital hypothyroidism diagnosed diagnosed at birth via national screening program,
Very good.
and he was on thyroxine
Since
and
birth.
since
Okay.
birth.
Okay.
After that, he also had underlying G6PD deficiency diagnosed since birth via national screening program.
Okay.
Otherwise, there was he was very well until an admission due to respiratory disease
Otherwise, he was doing well apart from one admission 1 month ago because of respiratory disease
and require
virus
nebulizing.
nebulizer. Okay. So this is the background and included also the long-term medications we mentioned in it. What about control status? Control status here, once you said he was doing well, that is the control status. Because hypothyroidism is controlled well by his treatment. Yeah, so there's no extra phrases or extra sentences to add. If the patient has bronchial asthma, for example, or has epilepsy, then you need to tell how frequently he gets the convulsion, what is his baseline, how frequently he gets nocturnal symptoms. You need to give rough idea about his baseline. But here, it is hypothyroidism on treatment. So there is no thing to talk about baseline. Yeah. So no extra phrases or sentences. Number three, long-term medications we already mentioned. Number four,
Number of
number of admissions. So we have to say he was admitted for the second time now, or he was readmitted again now for the second time because of
because of um, rapid breathing and chest recession during the examination at the GP.
you
Okay.
see. What is number five in the summary? What is number five in the summary?
Indication of admission with main complaint.
Okay. What is the indication of admission in this case?
Fever and cough. For
No,
this, no.
I can tell you. I see many children with fever and cough, and I don't admit them. No, this is not indication. You cannot convince me.
He was referred from the GP due to increased respiratory and chest recession.
GB will not force me to admit the child. I can see the child with fast breathing, and I don't admit. I can manage as outpatient.
Recurrent symptom.
Recurrent symptoms does not need treatment. Why they admitted the child? See, the child has significant symptoms, and they give nebulizer at ED. They have given nebulizer at ED, but patient did not respond. Patient did not respond. So you have to tell that. Was admitted again because of fever, cough for 2 days, followed by rapid breathing, and did not respond to nebulizer as outpatient treatment. Yeah. So now you convinced me. Patient did not respond. I will not keep the child die in front of me. Yeah, I need to admit the child. Yes. So always, because you will face that when you start working after that, especially you know the situation in Malaysia. Now with COVID-19 is different. The wards are not occupied. Most of the children are at home. Most of the people don't come to the hospital. But before that, when you go to HTAA, the ward is full, and they add extra beds. If you go to HKL, one room supposed to have 4 beds only. They put 8, means double the capacity. And your society is growing. Number of children is growing. So that's why you have to be particular. Who needs admission? Who does not need admission? If the specialist doing the round find every case admission, he will not be happy. He will say, why did you admit this child? Why did you admit this child? So your answer must be ready. I admitted this child because he failed to respond to outpatient treatment as nebulizer. So no one will argue with you after that. Child is indicated for admission. Okay, carry on.
Carry on with physical examination. The patient was examined after he had received nebulized budesonide and salbutamol. First, from general inspection, the patient was alert and active, not toxic looking. He was sitting comfortably on his mother's lap while playing with his toys. He was not in respiratory distress as there was no nasal flaring, expiratory grunting or chest recession observed. The respiratory rate was 30 breaths per minute.
Grunting. What is grunting? What is grunting? Anyone knows? Did you hear grunting before? So after we finish the class, you go to YouTube and listen to grunting. There are videos for grunting. You can see grunting. So because we need to differentiate the noises, the respiratory noises. Okay, can someone tell me what noises do you know? What noises? What respiratory noises you know? Yes. Any noisy breathing, any type of noisy breathing or respiratory noise, you know?
Stridor.
Stridor, very good. Stridor is one. Okay. Number two, wheeze in this case. Now he mentioned the grunting and snoring. So the four common sounds are stridor, wheezing, grunting, and snoring. So let's take one by one. What is stridor?
Partial obstruction
Uh-huh.
of
Of
upper respiratory tract.
upper respiratory, upper airways. So you can tell it is noisy breathing. It is noisy breathing caused by turbulent flow. Turbulent flow. When you have noise, you have turbulent flow. It is noisy breathing caused by turbulent flow due to obstruction of the upper airway. Obstruction of the upper airway. This is a stridor. Example is croup. Croup is viral infection. This is stridor. It is something caused by the upper airway. So stridor can be inspiratory, can be expiratory, can be biphasic. Biphasic I cannot imitate. Difficult to imitate. Yeah. Biphasic means during inspiration and expiration. Wheeze. Just now someone give the definition of wheeze. Can she repeat again? Who told us
Whistling
the definition?
sound
Yes. Mm-hmm.
due to partial obstruction of lower airway.
Yes, partial obstruction of our airway. So wheeze typically expiratory. Wheeze typically expiratory. But if severe obstruction, it may happen also during inspiration. Grunting is different. Grunting is noisy breathing caused by forced expiration against partially closed glottis. Grunting is noisy breathing caused by forced expiration against partially closed glottis. Grunting is ominous sign. Ominous sign, ominous, O-M-I-N-O-U-S. Indicate impending respiratory failure. Impending respiratory failure. So that's grunting. How is it? That's grunting. That's grunting. It is ominous sign. If you see any patient, child or adult with the grunting, you have to prepare for intubation. Means your patient is going to respiratory failure. Snoring, I am sure all of you have heard snoring at one time. What is the definition of snoring?
Doctor, can I try?
Okay, try.
Snoring is the noisy breathing when the air flows past the relaxed tissue in our throat, causing the tissue to vibrate.
Oh, very good. Very good, Faiz. Yes, it is caused by vibration. So snoring is caused by vibration. Stridor is turbulent flow, but snoring is vibration. Very good. How is snoring? All of you have heard snoring. Commonly inspiratory. So no need to imitate snoring in front of you. Or if you know how is snoring. What is the most common cause of snoring? The most common cause of snoring?
Obstructive sleep apnea.
Obstructive sleep apnea is a pathological cause. Yes, it is common in obese people. Obese people commonly snore, especially those who have obstructive sleep apnea. Snore. Is there another cause? Habitual. Habitual. Habitual means the people, many people, they are not obese, but you cannot sleep beside them because they snore. They snore. So my children, first one Muhammad is not obese, second one Abdurrahman. So Abdurrahman cannot sleep beside Muhammad. Every time if he sleep beside him, he wakes up in the middle of the night and leaves the room. He said, I cannot sleep beside Muhammad. He snores a lot. So habitual snoring. Okay, carry on.
Okay. The respiratory rate was 30 breaths per minute. The patient occasionally produced barking coughs. There was a branula attached on his right dorsal hand with no active infusion. His physical size seems appropriate for his age. Otherwise, there was no dysmorphic features. Next, for general.
Did you see the genitalia? Did you see the genitalia?
No, tak ada. There's
So
not.
you say no obvious dysmorphic features.
No obvious.
Yeah. Okay.
Okay, next for general examination. On peripheral, the palms were warm. The capillary fill time was less than 2 seconds. There was no peripheral cyanosis, finger clubbing, leukonychia, koilonychia, or palmar erythema. Other infective endocarditis signs such as splinter hemorrhage, granulation, or slernut were also absent. PCG scar was seen on his left delta area. Next, on head and neck examination, there was mild conjunctival pallor. There was no scleral jaundice, no sunken eyes or coated tongue, no injected pharynx or enlarged tonsils, no central cyanosis observed. There was no lymphadenopathy. The trachea was centrally located and the jugular venous pressure could not be assessed. On lab examination, there was no pedal edema. For vital sign, the blood pressure was 90 over 50 millimeter mercury. The pulse rate 140 beats per minute with regular rhythm and good volume. The body temperature 37.9 degrees Celsius. Next for anthropometric measurement, the weight was 8.0 kilogram, the height 67.0 centimeter, body mass index calculated, which was at 17.8 kilogram per meter squared, which was normal. The head circumference 44 centimeter. Next, proceed with systemic examination. First, respiratory examination. On inspection, there was no chest deformity, scars, or dilated vein. The chest moved symmetrically with respiration. On percussion, both anterior and posterior side were resonant at all zones. On auscultation, both anterior and posterior sides have vesicular breath sound and equal air entry with no added sound. The chest expansion, tactile and vocal parameters could not be assessed in this patient.
Usually we don't do. This one needs to do in internal medicine. We in pediatric we don't do. Okay.
Okay, next for cardiovascular examination, the radial pulse could not be appreciated. The radial and radiofemoral delay were not assessed. On inspection of the precordium, there was
You
no
need to assess the femoral pulses. Yes, radiofemoral delay we don't assess, but is the femoral pulses good volume or no, or weak volume? How is the volume of the femoral pulses?
the femoral pulses is not stated here, but
Okay, so I know it is not your case. So if you clerk by yourself, you check the femoral pulses, good volume or not. Okay.
okay, on inspection of the precordium, there was no visible pulsation, scars, or dilated vein. On palpation, the apex beat was not displaced, situated at the fourth intercostal space on the left midclavicular line. There was no trill or parasternal heave. On auscultation, S1 and S2 were heard with no murmur and no added sound. On abdominal examination, on inspection, the abdomen was not distended and moved with respiration. The umbilicus was centrally located and was inverted. There was no scar, visible peristalsis, or abnormal pulsation observed. On palpation, the abdomen was soft and non-tender. The liver was palpable 1 centimeter below the right costal margin. The liver span was 5 centimeter. The spleen was not palpable. Both kidneys were not palatable. On percussion, shifting dullness was negative. The throat space was negative. On auscultation, no bowel sound was heard for 12 times in a minute. For neurological examination, the pediatric Glasgow Coma Scale obtained was 15/15. There was no abnormal posture, muscle wasting, or fasciculation. Both upper limbs and lower limbs have normal tone, power at least 4/5, and reflex 2+. Babinski sign was outgoing. The proprioception, sensation, cranial nerve, and cerebral sign were not assessed.
Okay. Can you repeat the auscultation of the respiratory system, auscultation of the lungs?
Auscultation, both anterior and posterior side have vesicular breath sound and equal air entry with no added sound.
No added sounds. So what do you think why the child has no added sounds? What do we expect based on the history? Based on the medication he required nebulizer. What did we expect? We expected to hear. He required a bronchodilator. So we expected that he has bronchoconstriction. So what noisy breathing we expected to hear? Wheezing, yes. So it is wheezing. When you auscultate by stethoscope, you say ronchi. You say ronchi. When you hear by your ears, you say wheeze. So they are the same. Wheeze and ronchi, they are the same thing. You say wheeze is correct. You say ronchi is correct. But commonly, we say wheeze for the one which we hear without stethoscope, and we say ronchi for the one which we hear by stethoscope. Some references tell you different things, but don't be confused. This is the common consensus. Wheeze heard without stethoscope, ronchi heard with the stethoscope. So why we couldn't hear any ronchi? Because your patient was examined after
After the nebulizing.
After the nebulizer. So your patient started to improve. So likely your patient has good prognosis, likely he responded well and discharged home. So diagnosis, what you think the diagnosis?
From the knee right up, the diagnosis was viral croup.
Viral
Croup.
croup.
Mm.
So in case it is viral croup, so what was the noisy breathing here?
It was barking cough.
Barking cough is not noisy breathing.
It was
Stridor.
Stridor. Stridor, very good. Stridor. Okay. What is the cause of the viral croup?
The causes is virus infection, such as
Which virus? Which virus? Parainfluenza.
influenza virus
Parainfluenza. Which type of parainfluenza?
type 1, 2, and 3.
Okay, commonly 1 and 3.
1 and 3.
Okay. Okay. What other viruses? Any other viruses can cause croup?
Other viruses such as respiratory syncytial virus,
Mm-hmm.
adenovirus,
Okay.
and influenza virus.
Influenza virus, yes. Okay. Syncytial virus, adenovirus, and influenza virus. Adenovirus, which type of adenovirus? Seven and 21. 7 and 21. Respiratory syncytial virus, which types? We have A and B. We have A and B. Yes. Influenza?
A and B.
Influenza also A and B. Influenza also A and B. Okay. So which one of them is more likely? Among these viruses, which one is more likely?
The most common is parainfluenza virus.
The most common is parainfluenza. But in this case, there is suspicion of adenovirus. If you go back to your history, there is one feature suspicious of adenovirus. You go to the GIT symptoms. What are GIT symptoms the child has?
He has loose stool.
Yes, he has diarrhea. So adenovirus commonly affects both respiratory tract and gastrointestinal tract. Yes, if they ask you what is the most common virus which cause croup, it is parainfluenza. It is parainfluenza. But in this case, I will suspect adenovirus because of diarrhea. Because of diarrhea. What is definition of croup? Croup is what type of infection croup?
Croup is a viral inflammation of the
Inflammation of
larynx, trachea, and bronchi.
yes, laryngotracheobronchitis. 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 That's croup. So that's why don't surprise if you hear bronchi in croup because the bronchi may be involved and you may hear bronchi. Yeah. Okay. So how to treat croup? Or first tell us investigation. What investigations they have done? What tests they have done?
For investigation, they have did full blood count
Full
and
blood count. Okay. What is the benefit of full blood count?
full blood count we can know the level of the value of white blood cell and the differential.
Very good. If you have high WBCs and mainly neutrophils, this indicates
Bacterial infection.
bacterial infection. Which bacterial infection can present like a croup? Can present with stridor, but that has very high fever and drooling, toxic looking. Which bacteria? Condition called bacterial tracheitis. Bacterial tracheitis caused by staph. Bacterial tracheitis caused by staph. Okay. Okay, what other investigations they have done?
Other investigation, they also did iron studies for the patient.
Why
Because,
iron study?
because from the food blood count, the hemoglobin level was low, and also the mean corpuscular volume and mean corpuscular hemoglobin, which the MCV and MCH was low, suggestive for hypochromic microcytic anemia. And
What are
then
the cause of microcytic hypochromic anemia?
the causes of hypochromic microcytic anemia is one of them is iron deficiency anemia.
Then another thing common in Malaysia,
The thing is thalassemia.
thalassemia. Very good. So if you mention these two, that these are on the top. So iron deficiency anemia and thalassemia on the top. Other causes?
Other causes.
Yeah. Now for distinction, when you mention iron deficiency anemia and thalassemia, that's you pass. Now if you want distinction, you tell other causes. Yes, Amir? Yes, Amir?
Anemia.
Uh-huh.
Sideroblastic anemia.
Oh, Amir, good distinction. Sideroblastic anemia, congenital sideroblastic anemia. Yes, congenital sideroblastic anemia, lead poisoning and copper deficiency. Congenital sideroblastic anemia, lead poisoning and copper deficiency. These are the common cause of microcytic hypochromic anemia. How to differentiate between iron deficiency anemia and thalassemia? Did you see the RDW? Is it written the RDW?
No.
RDW.
No, doctor.
Okay, RDW, RBC distribution with it. Red blood cell distribution with it, which measure the degree of anisocytosis and poikilocytosis. It is high in iron deficiency anemia. We can differentiate by high RDW. High RDW is feature of iron deficiency anemia. Anyone knows Mendzer index? Mendzer index.
No, doctor.
Okay, Mendzer index is MCV divided by RBCs. Do you have the RBC count? How many RBCs?
RBC was at 4.30.
4.30. MCV?
MCV 56.3.
56.3. Okay, can we all do? Divide 56.3, divide by 4.3. 56.3,
56.3.
15.1.
56.3, divide by 4.3.
13.9.
13.9.
0.1.
So, this is compatible with thalassemia rather than iron deficiency anemia. Yeah, when you have low Mendzer index, less than 15, less than 15 or less than 14, it is compatible with thalassemia. If more than 14, it is iron deficiency anemia. But this is not confirmatory. Iron study is indicated. Iron study is indicated. Iron study is indicated. If iron study, so what tell you it is thalassemia or iron deficiency anemia? What do we do in iron study? What investigations we do in iron study?
We do serum iron,
Serum iron, okay.
total iron binding capacity,
Total iron binding capacity, yes.
transferrin saturation, and serum ferritin.
Very good. So tell me the result if iron deficiency anemia and if thalassemia.
If iron deficiency anemia, it will have reduced serum iron, increase total iron binding capacity, reduce transferrin saturation, and reduce ferritin.
Very good.
For thalassemia, the serum iron, the transferrin saturation, and serum ferritin would increase. Meanwhile, the total iron binding capacity would reduce.
Very good. Correct. Correct answer. Okay. So this is the difference between iron deficiency anemia and thalassemia. Okay. What else was done for the patient?
Other than that, Coombs test was also been done to the patient, and it was negative.
Okay.
And then chest X-ray. For the
Chest
chest,
X-ray. Okay.
for the
So
chest,
approve. What is the sign? Is there any sign in the chest X-ray?
for the chest X-ray for this patient, there was no stipple sign. That
Stable sign. Very good. Can you tell them what is a stable sign?
stipple sign is like a minaret of the moss, like a pencil.
I
Pencil
see. I
point.
see. Yeah, it is narrowing. It is, you
Of the
see, it is wide part, then narrowing, then wide again. So wide part, then narrowing, then wide again. That's stable sign. Steeple. Okay. Okay. What else they have done? Have they done electrolysis and calcium?
For calcium, the serum calcium was low,
How much?
2.15.
It's okay. 2.15. It's okay.
And then the patient also did renal profile,
Mm-hmm.
and the patient had hyperkalemia for
How much?
5.4. I think it's not
It's okay. It's
5.4.
okay. It's okay. Do you know what is the cause of this hyperkalemia? Do we expect hyperkalemia in a group? We don't expect hyperkalemia. What is the likely cause? Hemolysis. When doctors take the blood sample in children, it is not easy, not like adult. Adult, they have large veins, so you insert the needle and take the blood large amount, no problem. In babies, sometimes we have to squeeze to get good amount of blood. We have to squeeze and squeeze. So this can cause hemolysis of RBCs, and when hemolysis happen, potassium comes out from the cells, so they will have hyperkalemia. Okay.
Doctor,
Yes.
can the hyperkalemia be from the G6PD because of the hemolytic anemia?
No, we don't have. If it is hemolysis from G6PD, we don't have hyperkalemia. It is more when we have squeeze and breakage outside during the blood intake. Mm-hmm.
I think that's all for the investigation.
Okay. So treatment.
For treatment, the patient was given budesonide and salbutamol nebulizer,
Mm-hmm.
and also syrup paracetamol,
Who was given? Budesonide and
salbutamol.
salbutamol. Salbutamol, in fact, is not needed for croup. If it is croup, maybe it is a combination. Yeah, salbutamol is not needed for croup. Salbutamol is not needed for croup. Yeah, because the main problem is the upper airway. Why steroids? Why budesonide for croup? To reduce inflammation. To reduce inflammation. Okay. What
Okay,
else was given to the patient?
and then he was given paracetamol
Uh-huh.
and folic acid,
Folic acid. Okay.
and he was planned to be transfused with PEG cells 2 times, and that was given. He was given PEG cell transfusion.
Was the patient from HTAA or from here, from UIA?
from HTAA.
I see. It is unusual to transfuse G6PD unless they have acute hemolysis. Unless they have acute hemolysis. So a bit confusing. Now, I think we cannot make argument with you because you are not the one who clerked the case. Yeah.
And
Okay. What else?
that's all for the medication.
Medication. Okay, if I ask you about management of croup, how do we manage croup?
For group management, first we have to manage the airway and treat the hypoxia if the patient have hypoxia.
Mm-hmm.
And then it was classified into moderate, severe, and moderate, mild, and severe group. For moderate and severe, we use nebulizer epinephrine.
Mm-hmm.
And then we also give corticosteroid to reduce the inflammation and antipyretics.
What is the risk of epinephrine? What is the risk of epinephrine? So epinephrine is good because it controls edema. It causes vasoconstriction, so reduce edema. But epinephrine is dangerous. It can cause rebound. It can cause rebound obstruction. So if you give epinephrine, your patient must be in the ward. Don't give epinephrine as outpatient. Epinephrine is for inpatient. For inpatient. Okay. Any questions?
Doctor, I have question, but it is a bit out of topic from the respiratory. I want to clarify if for the abdominal examination, do we have to calculate the liver span or just do we have to calculate for the liver span? Because different doctors have different views about liver span.
Yeah, I think Dr. Sayyid Abdul Khaliq, he says we don't calculate liver span, is it?
Dr. Fazil.
Dr. Fazil says we don't calculate liver span.
Oh.
We only calculate, yes, Dr. Fazil, because Dr. Sayyid Abdul Khaliq was one student with Dr. Fazil. Yeah. Yeah. I hear that, honestly, I hear that also. I hear that from them. I hear that from them. But I did my master in University Malaya, and I was doing liver span, and consultants there didn't comment. Consultants there didn't comment. So this variability, I mean, you will find that one lecture tell you something, then the other lecture tell you something different. So take both of them, and you go by yourself, see the references. Yeah. Then choose which one you like. The one which has more evidence, you feel that is the correct one, you take it. And don't worry, you will not fail in your exam because of this point. Even if I am the one who is promoting check liver span, the other examiner comes with me is not promoting to check liver span. We will not make you fail for any option you choose. Okay. Any other questions?
Doctor,
Yes.
for lionization just now, is it, does it can be caused by acquired?
Yes, it is. It is acquired. Yes, suddenly, for unknown reasons, one girl, her normal X chromosome becomes inactive. So the other abnormal X chromosome takes the upper hand, and the disease manifests.
Is there any risk factor or predisposed causes?
Risk factor for lionization. I didn't read before. Yeah, funny risk factors which lead to lionization. If I get time, I will read. And also, please, also, you go and read if you find risk factors. And if you find something, please WhatsApp to me. Okay.
Doctor, I have question.
Yes.
For very group, it's laryngotracheobronchitis.
Mm-hmm.
Bronchiolitis is the infection in the inflammation at the bronchiole.
Yes, correct.
So the presentation might be the same. So to differentiate it.
No, bronchiolitis doesn't cause stridor.
Oh.
Bronchiolitis stridor تدا. كلو أدا stridor means croup.
Do we need to do laryngeal scope?
No, you don't need. Because stridor or barking, cough, or hoarseness of voice, something is audible. Something is audible. You don't need. Unless you have severe stridor with obstruction and you are suspecting like foreign body or something in the upper airway, then that is different situation.
Okay, thank you.
Welcome.
Doctor,
Yes.
for group like symptom like in bacterial tracheitis,
Yes.
when should we start to challenge the patient with antibiotic?
Okay, if the patient has very high fever, toxic looking, and drooling of saliva, then antibiotic is indicated. Again, high fever, toxic looking, and drooling of saliva. Okay. Did you prepare only one case or two cases? One case only, yeah?
Yeah, two cases.
Okay. You prepared two cases. Who has the
Yes.
second case?
Me.
You. Okay, we
Yes.
have to go very fast because now 11:50 and we need to go to Salat al-Jum'ah.
Okay.
Give me just few minutes. I need to go to the toilet. Then we continue with you.
Lapar.
Quite.
Okay, can start your case.
Okay, so this case is about Fahim, a 3 year 2 months old Malay boy presented to emergency department of IUMMC with history of an episode of fitting for 2 minutes duration associated with fever. So he
So
was apparently
unfortunately, your case is very interesting and needs a lot of discussion. Yeah. Okay, maybe if we another time, if we have another class, we can take another case with fitting and fever. A lot of discussion in the history, in the physical examination, in the investigation is needed, in the management, a lot of discussion. Sure, this time which we have is not enough. So now we take it briefly, but it is good if you have another class with me, you present another case with fitting.
Okay, so he was apparently well until 2 weeks prior to admission. He developed a low-grade fever, which is intermittent in nature and did not associated with chill and rigor. It is associated with runny nose with clear nasal discharge. Um, Worrying of his symptom, his mother brought him to Clinic Al-Razi and was given antibiotic and antibiotic. The symptoms subsided after about a week following medication given by the GP. However, 3 days
Can you
prior
stop
to
for a while?
admission,
Stop for. I need to bring the charger because the battery is going to finish.
Korang penat bila? Apa ni?
Okay.
okay, I proceed. However, 3 days prior to admission, he started to develop high-grade fever. The temperature documented at home was 38.7 degrees Celsius. It is associated with sore throat. He also developed cough, which is productive in nature for 1 day duration. The sputum is whitish in color of minimal amount for about 4 times a day. His mother also noticed of his poor oral intake, whereby he did not finish his bottle feeding and refused to eat porridge when given by his mother. He also became less active, whereby he would just lying down in front of the television instead of playing or walking around as he usually did. At around 10:30 p.m. prior to admission, he suddenly developed a fitting episode witnessed by his mother. His mother noticed that there were uprolling of eyeball, drooling of saliva, stiffness of his upper and lower limb, and he did not respond to call. There was no bluish discoloration, no tongue biting, no bowel or urinary incontinence. Her mother immediately did lateral positioning of her child during the feed. The feed occurred for 2 minutes and aborted spontaneously. After that, his mother immediately gave him suppository paracetamol and later brought him to emergency department. And he was warded at 2:30 a.m. the next day. There was no more fitting episode occur after admission. On further questioning, the mother claimed that this is the 5th hospital admission due to febrile fit. The last fit was in July and he was warded at Hospital Shah Alam. For each episode of fit previously, the presentation was same. Otherwise, none of his parents had any history of childhood febrile fit. According to his father, there was no rashes earache or ear discharge. There was no headache, neck stiffness, photophobia or change of behavior. Her mother denied any loss of his weight. No history of head trauma or injury. There were no history of travelling or water-related activity. For systemic review, generally there was only fever and loss of appetite.
Sorry, doctor, we can't hear you. Still cannot. Okay, doctor. Okay. Doctor, try to talk. Try
Do you
talking.
hear me now?
Yes, yes, we hear you.
Yes.
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 Okay. Uh, so, are you sure he has febrile fits?
Because it is associated with fever.
It is associated with fever. You see, febrile fits, first, it is diagnosed by exclusion. When you see a child with fever and fits, don't jump to febrile fits as first differential diagnosis. You must exclude the serious diagnosis, the serious condition which can kill the child or makes him mentally retarded and handicapped. What is that condition?
Encephalitis.
Yes, meningoencephalitis. We have to rule out meningitis or meningoencephalitis. So it is diagnosed by exclusion. Febrile fits after exclusion, when we exclude the serious problems, febrile fits is not indication for admission. Only first episode. First episode, we need to admit. First episode, we need to admit because we are not sure is it febrile fits or another problem. But after that, when the problem happens many times, we know that it is febrile fits, so we don't admit. So how come this child admitted 5 times? Strange. Yeah. Usually we admit first time for evaluation. After that, we don't admit anymore. Again, it is not your clerking, so we just listen. Okay.
Okay, for systemic review,
Mm-hmm.
from generally there was only fever and loss of appetite. For head and neck, there is no sign of neck stiffness such as crying when lying, no ear discharge, ulcers and gum bleeding, no bruises or head injury. For cardiovascular system, there was no history of shortness of breath, orthopnea or paroxysmal nocturnal dyspnea. For respiratory system, there was cough, sore throat and runny nose but no rapid breathing, noisy breathing, hemoptysis or night sweat. For GI system, there was no constipation, diarrhea, abdominal pain or parectal bleeding. For genitourinary system, no abnormalities such as porthy-urine, hematuria and changes in urinary frequency. For hematopoietic system, no bleeding tendency such as gum bleeding and bruises was noted, no pallor was noted. Musculoskeletal system, no muscle weakness, joint pain or bone pain and no swelling noted. For neurological system, no history of giddiness or abnormal movement noted. For past medical history and surgical history, this is his fifth hospitalization due to febrile fit. He was first hospitalized due to febrile fit at 1 year, 4 months age. Each fitting episode had similar presentation as current symptoms with stiffening of upper and lower limb and uprolling of eyes and drooling of saliva. His last fit was in July 2018. His father also complained of his recurrent tonsillitis for about 3 times last year, where his child will have difficulty to swallow, cough and sore throat. He was currently not on any medication or treatment. No operation has been done on this patient. For drug history, he is not on any treatment or medication. He had no known drug or food allergy. For immunization history, it is complete up to his age. Following the vaccination schedule, he had no allergy reaction following each vaccination he received. For birth history, antenatally, his mother
Okay, stop. Now, how old is the patient?
3 year, 2 month old.
Any comment? Remember, go to the previous lecture when I give you the history. Any comment about the way of presentation? Now, the child was hospitalized 5 times before, is it?
Yes.
Yeah. So which is better? You tell us previous hospitalizations and then you go back to the birth, or you go on one line? Especially in this case, we know the birth history is very important. In case of convulsions, case of fits, birth history is important. So when you go to the past medical history, it is good to go in one line. You go to pregnancy first. After pregnancy, delivery, what happened during delivery? After delivery, what happened after delivery? Then from delivery to first admission to second admission, until last admission, from last admission until now. So you go in one line. You go in one line. So can you tell us what happened during pregnancy?
Antenatally, Antenatally, his mother attended all antenatal screening and doctor told her that she had oligohydramnions. Otherwise, she did not have any complication during pregnancy such as GDM, intrauterine infection or pregnancy-induced hypertension. Intrapartumly, he was
Okay,
born...
wait. She has no intrauterine infection. What intrauterine infection which can cause fits?
Torch.
Torch, very good. Why torch causes fits? Because of calcification in the brain. Calcification. So what symptoms of torch may happen during a pregnancy?
Urinary tract infection.
No. Symptom of torch in the mother. Symptoms happen in the mother, infection goes to the baby. What happened in the baby is different from what happened in the mother. Baby will have congenital anomalies, have hepatosplenomegaly, jaundice, thrombocytopenia, lymphadenopathy, microcephaly, macrocephaly, mental retardation. That's the baby. Mother will have fever and skin rash. Fever and skin rash. So you need to ask specifically, do you have fever? Do you have skin rash during a pregnancy? Okay. Then what happened at birth, delivery?
He was born full term at 38 weeks of gestation via
Full term.
spontaneous...
Okay.
Yes.
Is this important?
Yes.
Yes. Why? What happens if the
Because
baby is born preterm?
the brain development is not...
Very good. Very good. Siti Noraina, very good. Brain development. So why that brain development leads to fits in the future? What the problem, what complication happens from this brain development which can lead to fits in the future?
The blood supply to the brain.
Oh, very good. Blood supply to the brain. What's wrong with the blood supply?
It is not it is not fully supplied the unreachable areas.
Okay. Preterm babies, they may develop intraventricular hemorrhage. intraventricular hemorrhage. Why they develop intraventricular hemorrhage? Because their ventricles are highly vascular and poorly supported. The ventricles are highly vascular and poorly supported. So they develop intraventricular hemorrhage. Intraventricular hemorrhage, which can lead to sequelae later and fits. That's why it is important to know whether baby was born term or preterm. What else can happen in the brain of premature babies? Periventricular leukomalacia. Periventricular, P-E-R-I, ventricular, V-E-N-T-R-I-C-U-L-A-R, periventricular leukomalacia, L-E-U-C-O-M-A-L-A-C-I-A. Okay, so that's why I said the case of fits needs long time, because a lot of events in the history and physical examination. So that's during a pregnancy. Liquor is very important. You ask about, she said oligohydramnios. Is oligohydramnios important in relation to fits?
I'm not sure.
It is related. Polyhydramnios or oligohydramnios are related, because when the child has polyhydramnios or oligohydramnios, there may be associated congenital anomaly. May be associated congenital anomaly. Like, or also if polyhydramnios may be associated with neuromuscular disorders. Neuromuscular disorders. Did you ask about fetal movement? It's not your case, it's someone else. Was there any question about fetal movement? There is no, huh?
No.
So with your self-Clark case of febrile fist, next time, ask about fetal movement. If the baby has reduced fetal movement, that is dangerous. Child may have neuromuscular disorders or placental insufficiency. Neuromuscular disorder or placental insufficiency, which can lead to fits in the future. If the baby has increased fetal movement, will you be happy? Faiz, the mother comes and tell you, oh, my baby has increased movement, moving a lot, a lot, a lot, a lot. Kicking, kicking, kicking. Will you be happy?
I'm not sure, but
Not
might
sure.
might be.
It is dangerous. Not happy, yeah? Don't be happy when the baby has increased fetal movement. But this one, you need the expert mother. Usually mothers first baby, they don't tell. But second baby, third baby, they can't tell, because they know the baseline. If the baby has increased fetal movement, that may be intrauterine seizures. Intrauterine seizures. You know, seizures may happen intrauterine. Seizures may happen intrauterine in two rare conditions. Two rare conditions: pyridoxine dependent seizures and non-ketotic hyperglycinemia. Pyridoxine dependent seizures and non-ketotic hyperglycinemia. You don't need to know deep details about these cases. Just you need to know that if the patient has increased intrauterine movement, it may be a feature of intrauterine seizures. Okay? Yes, carry on.
Okay, so his birth weight was 3.1 kilogram. The delivery process was uneventful. For postnatal, he had neonatal jaundice but did not require any hospitalization. His jaundice resolved after 4 days.
Jaundice secondary to?
Not mentioned here.
Not mentioned here. Okay. Now, is jaundice related to fits?
Yes.
Yes, answer is correct. How it is related?
Kernicterus.
Very good. Kernicterus. So kernicterus can lead to fits. What is kernicterus?
Bilirubin in the brain.
Brain. Very good. Which part of the brain?
Not sure.
Not sure. Very good. Basal ganglia and brainstem nuclei. Basal ganglia and brainstem nuclei. Okay. So did the baby cry immediately after birth? Did the baby cry or delay the crying?
Not mentioned here.
Not mentioned. It is very important. Why important? If the baby cry, means the baby got oxygenated early and the brain oxygenation was good. If the baby did not cry and require resuscitation, means there is hypoxic ischemic encephalopathy. There is birth asphyxia, which can lead to hypoxic ischemic encephalopathy and can lead to fits in the future. Okay. So I think we need to stop now because 12:15. We need to go to make wudu and go early to masjid to get the place. Any questions up to here?
Doctor, I want to ask regarding for my case. For viral induced wheeze, is it the same etiology with viral group, which are the virus?
Yes, yeah, it is the same. Viruses cause infection in the upper respiratory tract. After that, irritation, sensitivity cause bronchospasm, and the patient start wheezing.
Okay, thank you, Doctor.
Welcome. Okay, so Siti Noraina, sorry, we have to stop in your case. Your presentation is nice. Okay, you answer the questions, that's good. But unfortunately, we don't have the time to continue with it. Okay. Okay, assalamu alaikum.
Doctor,
And goodbye. Yes, yes.
Do I have to PM you personally for the marks for the long case?
Okay, can no problem.
Okay, I will
Yes.
text you. Please.
Yes, Siti Norain also can give her the mark because we are the ones who stopped the case, not herself.
Okay.
Okay.
Okay, thank you, Doctor.
Okay,
Thank you,
welcome.
Doctor.
Okay,
Thank you, Doctor.
Thank
Thank you,
you.
Doctor.
Bye bye. Thank you. Alaikum salam wa rahmatullah.